Hello, everyone. Welcome to Spine Talks. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation, and I am thrilled to be joined by the experts on our panel today, where we will be talking about opioids, pain, and spine health. Joining me on the panel today are Dr. Jeff Gum from Norton Leatherman Spine, Dr. Dan Shuba from Northwell Health, Dr. Praveen Bumanini from UCSF, and Dr. Mike Wang from the University of Miami. I am honored to have these experts joining us today. We're here today to talk about one of the most significant health crises facing Americans. And we have a role at the National Spine Health Foundation to talk about this with the experts who are treating spine patients. And so today we're going to talk about a lot of different topics around managing pain for spine patients and the appropriate role for different types of medications, including opioid medications, for managing pain. So I'm going to start our conversation off with talking with Dr. Gum and Dr. Shuba about their experiences with their spine patients in this very difficult topic. And I think one of the things we'll talk about first is what makes this topic so difficult. Dr. Gum.
What's so difficult is the majority of spine surgeries we do actually inflict pain on patients. So it's a lot of them are invasive. We try very hard to do minimally invasive type procedures, but with that type of surgery, we inflict pain, and we need medications to help control that pain post-op. Opioids are a part of that; they're not the whole picture. So what's difficult in our situation is we do these surgeries. They need some sort of medication or a combination of medications to help. But these medications can be very dangerous and lead to long-term consequences such as addiction or dependence. So that's a tough dilemma to be in with regards to spine surgery and opioids.
And first off, I'm just thankful you're bringing this up because this is such a big issue. And I think back to when smoking was cooler, whatever it was, and there were commercials, and everyone realized it caused lung cancer and heart disease. And we condemned that as a society. We realize all the preservatives that we have in food. We're realizing that causes diabetes and obesity. I don't think that people are realizing how pervasive this is, that basically every patient is 1 in 3 patients might have this effect. So as Dr. Gum said, patients are coming to us with pain, and as he said, it complicates it because sometimes the treatment exacerbates that pain. And so there's this catch-22 where we find patients saying, let's get you off narcotics before you have surgery altogether, but the reason they're coming for surgery might be because they have so much pain, so they're on narcotics. So what we have to do is we have to be creative, not only dealing with the person's own personal life, but also their personal surgical issues. So when we think of addiction or substance abuse, it's not just pain, it's also other aspects of their lives.
Right.
And so as surgeons, we have a unique position to see these patients in their family life, in their job life, in their function. And so in thinking about how to treat their pain, we also have to think about them as human beings. And if we don't, it's going to be the same issue that we saw with smoking and with obesity in this country. It's really going to affect everybody.
Yeah, and Dr. Gum, one of the things you and I were chatting about earlier was the concept that when patients come to you, as Dr. Shuba just mentioned, they've been experiencing pain. So maybe they've been taking some pain medicine, and now they need a surgery to fix the anatomical problem that they have to get them out of pain and functioning again. But in treating the pain from their surgery, you also have to take into consideration the fact that they might have already been taking pain medicine.
Right.
Doctors call this, naivete to the medication, right? There's medical language for that, and I think that complicates the picture for you all in terms of looking at each patient is individual and different in terms of their response to pain.
Very common that patients that have a problem that is bad enough to need surgery, that they're already taking some sort of opioid medication prior to the surgery. And there's lots of studies. There's actually tons of studies nowadays that show that they have worse outcomes. It's much more difficult to control their pain after the surgery. So opioid use prior to surgery makes it very difficult when it comes time to control their pain after surgery. And what happens is the pathway that they perceive pain actually gets amplified. So again, as Dan said, it's this catch-22. the thing overall, I think the big picture that's beneficial for patients to understand is opioids were designed for acute pain. Right? So they're designed to help pain after surgery. They're designed for break a bone or have some sort of injury for a very short duration. And when patients end up taking those medications for long periods of time, it disrupts the whole pathway of pain and how their brain perceives pain. So it puts us in a difficult position because it's really difficult to control their pain afterwards. That's why what Dan said, we need to be creative. We need to figure out ways to utilize it where it's needed, right, acutely after surgery, but to get them off very quickly and come up with other creative ways to help control pain and from a long-term perspective if they need it long-term.
We have a number of different pathways that we hit pain. We hit them from different arrows. Yes. And so, for example, a Tylenol, which people, take for granted, it's a very strong painkiller. When I am in pain, Tylenol actually, I think, treats me even better than an anti-inflammatory like an Advil often. But if you kind of treat that technique or that pathway with Tylenol and an anti-inflammatory and some of these other gabapentinoids, which help nerve pain, and maybe a steroid, and maybe an opioid, what you find is you don't have to go a high dose on any of them. Yep. So you can kind of start minimizing each level, and as a result, some of the side effects of any one drug at a high level will be minimized because you're spreading it out. The second thing to add to that is that most of the drugs that I just mentioned do not have as much of a dependency on them. What I mean by that is just as if you drink alcohol and you practice drinking alcohol, you can become better at drinking alcohol. In other words, it takes more to get drunk. And that happens, as Dr. Gum said, with opioids. And so what happens, though, is when you get to a certain level, your body almost needs that drug, requires that to keep its tolerance, to keep a homeostasis. And so what happens is when you stop that, you have side effects as well. And these patients hate these side effects, and that's why they keep using it. And I think with opioids, if I'm not mistaken, that can take as early as a week or 2 weeks to begin to have that cycle of dependence. Just like if you start drinking coffee a lot, you might feel that without your cup of coffee you have a headache. That might take a few weeks. The same is true of opioids. Not so much true of the anti-inflammatories or Tylenol. So what we're finding is if we can increase the distribution of the different meds into some of these other medicines, which don't have as much of a addiction profile, might be helpful to patients. Again, we got to get them early because once they get into that, it's hard for them to stop and then becomes the vicious cycle.
Patients often come into the pre-op area already on opiates, perhaps on long-term opiates, and we have to figure out a strategy to wean them off of these opiates after surgery when they acutely have more pain. So we've got to come up with that plan lest we have patients who are on long-term opiates even after surgery and contribute to the national opiate crisis.
Mm-hmm. And Dr. Wang, we know that oftentimes from any surgery, whether it's a dental procedure or any other procedure in your body, when you get opioids for a surgical procedure, that can be the number one way that people become addicted. So we have an opportunity as practitioners on the prevention side to reduce the likelihood of addiction happening following surgery. Can you comment on that topic?
And I like that you bring up the dentist, because I think that spine and dentistry is similar buckets because we're feared. So where someone can have a hip or knee replacement and they're just told you need to do the rehab and this is just a process and the protocol and the pathway, with spine, as Praveen indicated, they come in on pain medicines or they never would have the surgery. And then afterwards, the fear component is just like a prevailing part of their recovery. So I think we have a lot to do, a lot of homework to do with the National Spine Health Foundation in terms of educating the public on this.
Yeah.
Reduce their fear.
Yep.
And reducing fear. And Dr. Schuberg, you were talking previously about sort of a cocktail approach to pain management, post-operative. After you've had surgery, how do you manage pain and lots of different medication modalities? And I think that's so brilliant. I'd actually never heard it explained in that way. And I'd sort of like to hear from the panelists your comments on that as well. So different ways of managing post-operative pain with sort of different classifications of medications. Dr. Gutt.
Yeah. So as Dan brought up, we know that exposure to opioids sets you up for potential dependence or becoming addicted to them. And that's based on duration of using opioids and the dose that you're given. And so Dan's point that he brought up is we're becoming a lot more creative on attacking other pain pathways to reduce that opioid exposure. NSAIDs, which is tough in spine surgery a lot because the context of potentially inhibiting fusion. So that traditionally has not been very heavily used, but now we're becoming, we're introducing that more and more in pathways afterwards. Gabapentinoids, as Dan said, Tylenol, things like that. So the goal overall, though, is to attack pain from multiple different pathways so we minimize that opioid exposure, which reduces the chance for dependence down the road. And I honestly think that the number one thing to make an impact on this early is education, right? So there's tons of patients that come in, at least in my area of the country, that have been on opioids long term, and nobody's ever educated them on the detriment of that or the downstream effects. And so if you just at least introduce the potential to the patients that these can be addictive or are very addictive, and you can get addicted to them, I think that goes a long way to start the conversation.
Yeah, and the crisis of addiction in the United States is such a massive challenge. And what we want to do as spine experts is figure out what role we can play in this big problem that's facing our country. And so we've talked about multimodalities of pain management after an operation, why that can be challenging. One of the other things that people hear about and sometimes talk about, and that we've actually studied in the foundation, is this concept of enhanced recovery after surgery, or an acronym that's called ERAS. And I'd love to hear from our experts what their experiences have been with that, what the promise of ERAS is, maybe what the challenges are, and if that's something that patients should be looking for when they are going to have their treatment. We'll start with you, Dr. Wang.
Well, ERAS is a fascinating concept, and we instituted it at the University of Miami to change the way people are fast-tracked through surgery. And, the hospital loves it because the amount of cost savings are tremendous. Patients, of course, benefit because they mobilize faster, they have less pain. And there's another dimension of this I think it's worth entertaining, which is we tend to focus on the fact that people come in on meds, and then we give them more meds after surgery. But there's also a different subset of patients, which is actually quite large, which is people that are not getting help with surgery. So people either out of fear or miseducation or lack of referrals or resources, and that being told they just got to live with this pain that in many cases can be fixed with a surgery. And so surgeons are at this crossroads, right? We try to be conservative, but also fixing people properly is another way to reduce opiate dependence and exposure.
Yeah. Dr. Miminini, are you experiencing ERAS protocols in your hospital?
Yes, we've implemented ERAS protocols. We've implemented it primarily around awake spine surgery. Wow. Because we want to perhaps not even use any anesthetic, a spinal anesthetic, but no general. And then we need to mobilize those patients quickly, and often they discharge the same day or the next day. But this can be done with the protocol, which everybody follows, and all the resources are applied appropriately upfront in order to optimize patient outcomes.
Yeah, and so with ERAS, there is a decreased need for pain management, right? That's part of the thing. Dr. Shuba, what are your experiences with ERAS?
Yeah, just to kind of jump on the idea that we're all talking about, again, the education and the thinking of this about an insult with surgery or an incision and having pain afterwards. So there's a lot of data now, and this comes out through our ERAS protocols, where you give medicines before the surgery, the same medicines. And what that does, it almost numbs the patient up. Oh. And because there's some data showing that the longer someone is in pain, the more the body reinforces that to the brain, whether it be the pain itself, or as Dr. Wang said, with kind of an affective, meaning an emotional response, which is the suffering aspect of the pain. So if you can numb someone up through what we call pre-medical or pre-surgical ERAS, that's part of it, then when they have the insult, it's almost like if you were to, hit me in the arm after I'd already numbed my arm up, I wouldn't feel it. And then when the insult went away and the medication wore off, I might not need any medication whatsoever. So that's a little bit oversimplification. Yeah. But the fact of the matter is the ERAS starts actually before surgery and gets the patient ready so they have less stuff during and less stuff after surgery.
So it's almost like a prehab situation, right?
Right.
Yeah, Dr. Gall, how about you?
Yeah, so all fantastic points. I mean, one thing to point out that ERAS, there's a lot of components to it, but what we're talking about is the opioid minimization component. And what we've introduced, and I think all these guys have done this as well at their centers, is we start off with the cocktail before they go to the surgery, like Dan was talking about. That helps.
Drug cocktail.
The drug cocktail, right? Yes, the drug cocktail, right? That's Tylenol, maybe a gabapentinoid, maybe some sort of NSAID in some centers, and potentially acetaminophen or Tylenol. So the other components of it, which is relatively new in spine, is regional blocks, right? So erector spinae blocks. If you get a total knee, right, typically they're giving you some sort of regional block to reduce that pain exposure. So now we're introducing those in spine. Also at our center, when they go to sleep, they get no opioids for the most part. And it used to be the opposite of that, right? So if you talk to the anesthesia folks, when you put somebody to sleep, there's pretty much a hard stop on every single medication, right? Because it becomes toxic at a certain level. There's not a hard stop in opioids. You can put somebody to sleep, and as long as the airway's protected, you can back the truck up and put as many opioids as you want. But that delays their recovery. They don't get up. They don't mobilize quick. So we're reducing opioids when you're asleep. We're using regional blocks to help, right? And then the other thing is we've standardized the way we treat the pain afterwards in the hospital, right? When we first looked at our data, between 8 partners, the variability was massive, right? So now we standardize that and we escalate it appropriately. So there's a lot of components within ERAS, and there's a lot of components just within the opioid minimization component of it. And all these guys are helping lead the way on how to fight that component.
Yeah, it's remarkable the amount of effort and scientific exploration and discovery that is happening amongst the spine surgeons in trying to address pain management and reducing the need for opioids. And I think the public doesn't understand how much work has gone into this. And pain is such a complicated area. The neuroscience of pain is complex and different for every patient. We often hear patients saying, "Oh, I don't want to take an opioid. I don't want to take narcotics. I'm afraid I'm going to get addicted." I'd like to hear our experts, each one of you, share with us how you answer that question when a patient comes to you and says, I don't want any pain medicine. I heard I could get addicted and I'm afraid.
Those medications were designed to help treat acute pain, surgery, injury, break a bone, something like that for a short duration. So if you educate the patient that it's helpful in that situation, we just need to minimize how long you take it, what the dose is. Most patients are open to it. I'd much rather take that patient, though, than the patient that continues to want or need opioids long term.
Yeah, I would just add to that when I was in training, which seems like yesterday, but was many years ago, we were taught at that time, at least I was, that the patient could have no pain and you had to give them so many opioids to extinguish that. And when patients came back, when they came, we would say, you need more opioids, you need more opioids. So I actually think that comment, although it should be a chance for education with that patient so they're not nervous, that new approach of the patient is, I'd rather wait or use less, is refreshing to us, because we only 20 years ago were saying, no, you don't get it, patient. Trust us, you have to use a lot of opioids. Now the patients are actually helping us say, can we try to minimize this? And as Dr. Gum said, that doesn't necessarily mean zero, but I do it's refreshing for me, like Dr. Gum, I like that they're coming to us saying that, because it means that the field is changing, saying, this is potentially dangerous, can we think of something else? So together we can educate each other.
Yeah, that's amazing. Dr. Miminini.
Yeah, some patients require more pain meds than others, and some patients don't have, as Mike was pointing out earlier, that emotional quality to the pain. They can kind of stick through it and deal with it very well and don't need the opiates. So if they don't want the opiates, we minimize the opiates. If they need the opiates and they're crying in pain, then certainly we would give them. But I respect the patient that doesn't want the opiates, and we start looking for alternatives, liposomal bupivacaine, regional blocks, other things that we can do which are non-narcotic, so that we can try to keep them off the opiates if they don't want it, or give them the least possible dose.
Yeah, those are great points. And Rita, I really appreciate that question, because I want to draw a distinction between minimization and appropriate use.
Yep.
And the precision medicine, the personalized medicine aspect, because if you think about it, just like Praveen said, there are patients who have differences in their temperament, but there's also genetic differences in, for example, addiction potential. For example, in tolerance of opiate side effects, so their therapeutic window is large or small, and then sensitivity in response to particular drugs. And so we've talked about surgical strategies a little bit, not too much, but also because we all do MIS surgery here, but also these cocktails and prehab and ERAS protocols. And I think that you're right, that there are patients who are afraid of opiates. To me, those are the people that I'm not worried about. They're not the ones that are getting addicted, right? And I think having that personalized understanding of what a patient really is like. And one day this will be genetically phenotyped, right? It'll just be processed. And I think, Jeff, you've done work on that, right? You've looked at that, right?
Yeah, I honestly, I think that is, the way somebody metabolizes the opioids and their genetic profile sets them up for dependence or not. And we don't understand that yet. I think understanding that in the future is going to be a huge breakthrough on the way we customize the post-op pain protocol, right? So some patients that metabolize it quickly, that may have less likely to be dependent or vice versa. We don't know yet. But once, in the future, I see this as we're going to understand that profile and we're going to customize that post-op pain protocol with a certain amount of opioids that hits the sweet spot. It takes care of your pain, but sets you up to be very less likely to be dependent. But really good points.
Yeah. Fantastic. Each one of our experts is on our panel today because they have a special interest in the concepts around understanding opioids, pain management, and spine surgery. So I'm going to ask each one of our panelists to tell us what they're most excited about in terms of what they're seeing on the horizon for managing their patients in new ways in approaching pain management. So I'll start with you.
Yeah, I practice spine surgery in Louisville, Kentucky, which if you look at the density of overdose deaths and dependence, like this is right in the heart of the epicenter of where it's a huge problem in the country. And so our center is exposed to a lot of patients that have been on opioids long term. There's a county north of us where over 50% of the patients in that county are HIV positive because it's an open air market for addiction. What happened is opioids were everywhere, right? There's laws that were passed that reduce them, and now patients become dependent and use, street forms of this. So I'm excited about a change, right? So I want to see overall less patients dependent. And it's important for spine surgeons because we have to rely on these for the most part in a lot of our surgeries. And so I'm just excited about change in overall opioid consumption.
Dr. Shiva.
Yeah, I think it's been touched on a little bit, and I'm just going to amplify it a little bit. Dr. Wank started talking about this, the idea of precision and now even personalized medicine. Precision medicine is being very specific for the patient's health, maybe their genes, maybe their age, maybe their gender. Personalized medicine is now adding in the social factors of healthcare, right? Are they poor? Do not have access? Do they speak a different language of another country? And I can take even myself, and 5 years will be different than I am now. I can take myself and put me in another country, and I would have different access to healthcare. So this is very big and very complicated. The next thing I'm going to say is another word that comes out a lot is artificial intelligence. So are there patterns that we're going to see that I can't see myself? I see 5 patients in a row and I say, I'm going to tweak it just a little bit because you're similar to me. But what we may find is that with artificial intelligence, AI, that we'll be able to pick up patterns saying, Dan, this is a very different patient, even though it seems to look like they're similar based on their age or their problem they're coming to surgery with. They're actually very different. And if that can be picked up, we can make it more what we call personalized. And that personalization is going to change depending on the patient, but also where that patient is in their life and in their age. So it's going to be exciting.
We can do more and more minimally invasive than we've ever done before. And as we do that, the incision size is smaller, the blood loss is less, the hospital stay is lower. They're more amenable to having personalized medicine with an ERAS type of a protocol where we can get them in and out with the least amount of opiates. And as that develops with technology over time, we're going to see probably a frame shift in how we treat our patients.
It's very exciting what technologies are coming out. For example, new pharmacologics, new carrier for the drugs we use, routes of administration, using augmented reality to minimize suffering and pain, distractive methods, and even, for example, advanced methods of cooling or heating parts of the body to change the local inflammatory or pain response. To me, I think that the technologies are going to move very quickly, offering our patients opportunities to either use opiates better or to avoid using them.
Yeah, well stated. Well, this has been a fascinating conversation. We've just done an introduction, really, to the topic of pain management and spine and the spine patient. We know that 100 million Americans suffer with a neck or back condition every year. That's a lot of people. 1 in 3 people have a neck or back problem. We say it's you or someone you know. That translates into lots of people who need surgery and who need help from these experts. So they are seeing lots and lots of patients at very many stages of their spine health journey. In closing, I'd like to ask each one of our experts to leave us with a pearl, just a pearl of wisdom, perhaps some reason why each of you are excited about working with the National Spine Health Foundation to create patient education and to responsibly educate to the public the ways to manage pain and the different ways that can be done, of which there are many that we've discussed today. So maybe I'll start with you, Dr. Wang.
Yeah, Rita, I'm very excited because the National Spine Health Foundation, you guys are doing something that unfortunately all of our major societies are not doing, and I try to have a hand in all of them. But you're trying to go directly to the public. It's something that for some reason medical societies don't consider one of their core competencies or values. And that's unfortunate because it's not a vacuum. Right? There are other sources of information that are being disseminated that are either not scientific or improperly aligned or predatory, let's say, or financially incentivized. And what you guys are doing as a nonprofit is you're allowing us to communicate ethically and responsibly to the populace. Yes. I have not seen that happen very often, so I'm very excited about this.
We are in the era of personalized medicine, patient-centric care. We have to have the voice of the patient in what we do, and the National Spine Health Foundation is helping us to understand that voice of the patient and increase those lines of communication. I think it's incredibly important for the years going forward.
Kudos to you and your team, and this is really about involving the people. And so I think what we are not doing is saying this is what you should do as doctors and you listen to us. This is actually an interplay because the solution is going to come from the patients, because I'm a patient and I'm a provider. And so I have to be thinking about it about this as a patient, but the people out there who are listening to this realize that you're part of the solution. You can inform us. This is a play between the two of us, so we're going to learn this together.
Yeah, great comments from all three of you guys and Rita. So again, this is a perfect example of how the National Spine Health Foundation can be so beneficial. One of the biggest reasons why patients get in trouble with opioid dependence is lack of education. This is a perfect conduit for education. And so, again, these guys point out we're not telling you what to do. It's an open discussion. We're just trying to help educate folks that need help down the road.
We hope that this conversation has been enlightening for everybody who's listening. This is a really difficult topic. It's very challenging. It's multifactorial, like many aspects of medicine. And we are very blessed to have these healthcare heroes joining us to give the expert insight to the public for all of us to be able to make better informed choices so that when you do find yourself or a loved one with a spine condition, you have a trusted resource to go to educate yourself so that you can ask informed questions of your doctor and have an informed conversation. And I think that's what each of our experts are telling us here today, is that patients get better outcomes when they themselves are better educated, and you can have a better and deeper conversation with your doctor. And so that is our hope, and that is our goal. It's something that we cannot do alone, and we are very blessed to have these experts who are involved in the science, the discovery, the evidence development, and also treating patients. They put the best of science into practice every day, and we call it the miracles of modern spinal health care.